Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. The title of my presentation is Bifurcation Lesion Treatment Training with Simulation, the Mentice Experience. My name is Peter Zanden. I'm from Gothenburg, Sweden, and I've worked with endovascular simulation for the past 9 years at a company called Mentice. In this talk, I'll try to share with you a glimpse into what I work with, and then more specifically what I, together with my colleagues here at Mentice, have created with the help of Dr. Lassen. I'll try to give you a brief insight to how it looks and why we think it's useful. Then finally, I'll end by sharing my vision of what I believe the future could hold for this type of simulation.
For those of you who have no previous experience of my company, I'll try to give a brief introduction to what we do. So since its foundation over 20 years ago, our main product is a real-time free flight simulation aimed at replicating endovascular procedures inside the cath lab environment. When I realized that that is a really confusing way to put it, I instead tried to explain it by asking them to imagine a flight simulator, but for doctors. If you've listened to a presentation by anyone from Mentice in the past few years, we tend to mention what we call the vascular twin. Effectively, this means that we create patient anatomies, pathologies, and scenarios from real-world examples and allow our users to perform a myriad of different interactions with an array of virtually replicated clinical devices. Using a computer and our haptic unit that tracks the movement of clinical devices put into it, you control the flow of the procedure. While our simulation covers everything from neuro to BTK and structural heart procedures, in these last couple of years, my focus has been on the cardiology space. Our vision has been to create a complementary hands-on curriculum to assist the training of endovascular coronary intervention, all the way from med school through angiography, angioplasty, and all the way to the most complex interventions, allowing training in a safe and repeatable way. Most recently, in fact, just last year, I worked together with Dr. Lassen to create the solution that led me to having this talk for you here today. Together, we created a training solution for complex bifurcation techniques. But to allow this project to even begin, a new hardware was developed that allows us to track the movements of a guide catheter with 2 wires and 2 balloons simultaneously, a bifurcation hardware, if you will. Consequently, the Mentice physics model needed to be expanded to allow some very complex interactions. As you can imagine, balloons need to push on one another, stents need to be able to deform, and stent struts need to be possible to pass through and expand individually. And to top it all off, these calculations and estimations need to happen in real time. And while that alone seems kind of daunting, it's not really enough. Being able to practice or rehearse different techniques is useful, but we are all here attending this meeting because we realize it's not that simple. A very real problem is knowing whether or not what you're doing during this training is correct. And that is where the EBC and its participants of these meetings come in. Because you guys have consistently created something amazing, a comprehensive guideline for how to perform different techniques, bringing some semblance of consensus about how to approach different types of bifurcations. Not only that, but they are also constantly evolving and improving these guidelines based on new data and experiments. Well, while I imagine some can read through the material once or a few times and then know it by heart, I would argue that learning by doing might be even more effective. And being able to perform hands-on practice gives an even deeper understanding for at least most people. But learning by doing the traditional way can come at a cost if done incorrectly. However, on a virtual patient, there is no risk, no time limit, and you can repeat the same thing over and over until you master it. So for these reasons, we have integrated the EBC guidelines into our simulation, walking the operator through the steps of correctly performing these techniques. We currently have 4 different cases with automatic built-in guidance that tells and shows the operator how to perform some of the most common bifurcation treatment techniques. The way we have attempted to make this easier to learn and understand is twofold. The built-in automatic guidance give both written instructions and visual cues. These visual cues and instructions cover where to move and position your wires, how to size and position stents and balloons, and how to properly crush and open different stent struts for each of the different techniques, all based on the latest EBC guidelines. We also give immediate feedback if a step is performed incorrectly, or if there's something that could potentially cause problems going forward. We do this by constantly measuring how the devices move and how they are placed. In these cases, you can also utilize both IVUS and OCT to look at lesions and the results of your work, verifying stent deposition and expansion. And to add to this, you can also influence the cases in real time. Through what we call the Proctor app, you can influence the flow of the case by creating, scheduling, and triggering complications to occur at will, throwing a virtual wrench into the mix. My hope is that this will be used in low-volume centers to help increase adoption of new guidelines and allow operators to train and rehearse new techniques and gain the necessary hands-on experience while in a stress-free and safe environment. In high-volume centers, it enables independent learning to gain repeatable and proctored exposure to these types of complex procedures, thus freeing up proctor time that would otherwise be required from a senior physician. While I hope that most of you will be intrigued by this already, there is plenty of room for improvement and further development. I want to take this opportunity to share my and some of my colleagues' vision of where we think this type of simulation is headed. But to understand where it at least could be heading, I want to first show you an example of where it is currently at and what we're working on. For structural heart, we have an application that we call Cardiac Sculptor. It allows operators to recreate specific patient anatomies and perform rehearsal operations on the real patient data. Upon using the solution in Stockholm during mitral valve repair cases, they showed a reduction in procedure time of 3 hours down to 2. Clearly, it helps them to discuss the upcoming procedure in real terms and allows them to easier identify possible difficulties and complications, and thus being prepared to tackle them during a live operation. Effectively, it has allowed them to streamline the procedural workflow before the patient is even on the table. Speaking of tables, in order to improve the realism of the training, our simulators can be placed in and connect to several Philips and Siemens angio suites, utilizing real tables, controls, C-arms, and screens. And I believe that the combination of cath lab integration and patient-specific simulation is where we are headed. I envision that simulation can become even more integrated part of endovascular procedures. What if next to your patient fluoro screen, you also have a simulation screen that showed the virtual twin of that patient with the same anatomy, same pathology, and as you move with your devices inside the patient, the simulation follows along automatically. At first, simulation could be used to practice certain steps before you do them, perhaps help you find optimal angles for your C-arm or hint at areas that might need a closer inspection. The more realistic this type of simulation becomes, the more things it can do. Perhaps it starts giving you hints on sizing, where to go with your wire, and hint at what catheter could gain you the easiest and most secure access. At the least, it could help reduce fluoroscopy time and contrast use, but it could also help gather data from previous procedures all over the world and put that knowledge into your hands. With the advent of robotic solutions, eventually, they won't necessarily be hands at all.